Hello, I'm Hematologist Oncologist Dr. Tony Talebi, and this lecture pertains to the acquired underproduction anemias of Hematology and Transfusion Medicine Board Review Made Simple. Erythrocyte production requires healthy stem cells, correct microenvironment, cytokines, erythropoietin, iron, and vitamins. Any deficiency of the listed components may lead to underproduction of RBCs. Anemia of chronic disease. Case report. 65-year-old man with diabetes and chronic osteomyelitis. That's the key word. Presenting with normocytic anemia, hemoglobin 8, low retic count, low serum iron, low serum total iron binding capacity, low transferrin saturation, and high ferritin. Negative hemolytic panel, negative occult stool for blood. Anemia of chronic disease is seen in chronic inflammatory states such as malignancy, chronic infections, or autoimmune diseases. In children, even a minor acute infection may cause decrease in the reticulocyte production. Antimicrobial hepcidin production is upregulated by IL-6 during inflammatory states, which in turn inhibits mobilization of iron from tissue macrophages and absorption of iron from the gastrointestinal tract by decreasing ferroportin levels. This leads to anemia of chronic disease. Treatment: treat underlying chronic condition which is causing the upregulation of hepcidin, and consider erythropoietin-stimulating agents. Anemia of pregnancy may be multifactorial. 1. Due to increase in plasma volume by 40% during pregnancy with only 20% increase in hematocrit, so referred to as dilutional anemia of pregnancy. 2. Iron deficiency. 3. Folate deficiency due to increased requirement. 4. B12 deficiency due to possible lack of intrinsic factor. 5. Must-rule-out hemolytic anemia, GI blood loss, and aplastic anemia. Reticulocyte count. This is a test for the estimation of the actual number of reticulocytes with immature RBCs in the blood. Normal value is about approximately 1% of the normal RBC count, so about 50,000. Results vary and range from 0.5 to 1.5% of the total RBC count. Unexplained anemia in the elderly. Case report. 65-year-old executive on routine exam discovered to have slightly macrocytic anemia with hemoglobin 9.7. Slightly low platelet count, also key, low platelet count, normal WBC count with normal differential, normal ferritin, negative Solbyak, normal B12, TSH, negative Coombs test. Folate slightly low. So if you see macrocytic anemia, slightly low platelets, slightly low folate, think alcohol abuse. Check for GI bleeding, iron indices, B12, folate, renal function, TSH, testosterone, serum erythropoietin, and consider bone marrow biopsy if no answer. However, many cases remain unexplained. Iron deficiency anemia. Case report: 20-year-old female with very heavy menses presenting with fatigue and hemoglobin of 6.5 grams per deciliter, with low MCV, low iron, low transferrin saturation, very low ferritin, and high TIBC. Peripheral smear revealing hyperchromic microcytic RBCs. Causes of iron deficiency anemia. The two major trees are either blood loss or inadequate iron supply. Blood loss could be due to GI bleeding, menstruation, chronic hemolysis, such as PNH or cardiac prosthetic valves, dialysis, pulmonary hemosiderosis, in which iron accumulating in the macrophages is not available for use, pregnancy and lactation, and frequent blood draws or self-phlebotomy. The inadequate iron supply would be either from malabsorption, from gastric bypass, inflammatory bowel disease, parasites, celiac sprue, or abnormal transferrin function, or achlorohydra, which is common in the elderly, or poor nutrition. Worldwide, iron deficiency is the most common cause of anemia. In developing countries, hookworm infection will cause GI blood loss. In developed countries, non-parasitic GI blood loss and menstruation are the main causes. During infancy, iron deficiency is caused by excessive whole cow's milk, which is low iron content and may cause occult GI bleeding without iron supplementation, so be very cautious of that. Also, chronic hemolysis such as PNH and hemoglobinuria will lead to iron deficiency as well. Iron deficiency in adults must rule out GI bleeding and must rule out GI malignancies. Dietary iron exists in two forms, either elemental iron, vitamin C aids with this absorption, or heme iron in meat and liver, which is better absorbed. On peripheral smear, RBCs will appear microacidic and hyperchromic. Diagnosis will be low iron level, elevated CIBC, low iron saturation, and usually low ferritin levels, unless chronic inflammatory state in which ferritin might be slightly higher than expected since it's an acute phase reactant. The gold standard for diagnosis is bone marrow staining for iron, which is rarely done. To diagnose iron malabsorption, check iron level 1 hour after intake of oral ferrous sulfate. If the iron level has not increased by 100 milligrams per milliliter, malabsorption is likely. Treatment: uncomplicated iron deficiency anemia, oral ferrous sulfate, 325 milligrams, which contains 66 milligrams of elemental iron. Since the daily replacement requirement is 200 milligrams of elemental iron per day, 1 tablet 3 times a day is recommended. Iron is better absorbed on an empty stomach, but may cause epigastric pain. It's usually better tolerated with meals. Antacids will decrease absorption of the iron tablets, so be cautious. Patient cannot tolerate the pill iron tablet, then may consider the liquid form, but that also may stain the teeth, so use a straw. Consider parental iron if malabsorption state or failure of oral iron therapy. And the parental irons include iron dextran, which carries a very small but serious risk of anaphylaxis, so you administer a test dose. Other ones are iron sucrose, which is Menopar, iron gluconate, which is Ferlicid, ferromoxetol, which is Ferraheme, can actually inject 510 milligrams of iron in only 17 seconds. And you may see an increase in hemoglobin in 1 or 2 weeks. Megaloblastic anemia may be caused by either folate and/or Cobalamine deficiency, or drugs which impair red blood cell DNA synthesis, or sometimes thyroid issues. Macrocytosis is caused by nuclear cytoplasmic dyssynchrony caused by impaired DNA synthesis. Neutrophil nucleus may become hypersegmented, meaning more than 5 lobes. Since there's ineffective erythropoiesis, LDH will be elevated. Other causes include methotrexate, azathioprine, hydroxyurea, AZT, and myelodysplastic syndrome. Cobalamine B12 deficiency. Case report. 37-year-old female presenting with weakness and hemoglobin of 6, with elevated MCV, neutropenia, and thrombocytopenia, because B12 deficiency will eventually lead to pancytopenia. On exam, there's decreased loss of vibratory sense in the lower extremities, normal folate and TSH level, but cobalamine level very low, and methylmalonic acid, the MMA level, elevated. Humans cannot synthesize their own cobalamine and need to consume it to survive. Cobalamine is a coenzyme for 2 enzymes. The methylmalonyl coenzyme A mutase, in which succinyl-CoA is generated for the Krebs cycle, and the methyl tetrahydrofolate homocysteine methyltransferase, which allows folate to enter the cell. B12 absorption in the stomach, it's bound to R binders protected from acidity. In the small intestine, it's bound to intrinsic factor, which allows absorption in the ileum. Blood, it's bound to transcobalamine 2, which allows it to be absorbed by the target tissue. Causes of cobalamine deficiency. 1. Impaired absorption, which may include intrinsic factor deficiency, malabsorption, terminal ileum or gastric resection, medicines such as cholestyramine, bacterial overgrowth, fish tapeworm, hypochlorohydra, decreased pancreatic proteases, or it may be caused by reduced intake such as vegetarians, or congenital disorders such as deficiency in transcobalamine 2. Pernicious anemia is the destruction of parietal cells which produce the intrinsic factor resulting in cobalamine deficiency states. Possible board's question: recreational user of nitrous oxide presenting with neurologic deficits. What is the problem? think cobalamin deficiency, since nitrous oxide disrupts intracellular cobalamin metabolism. Patients with cobalamin deficiency may develop severe neurologic deficits due to demyelination of the dorsal and lateral columns of the spinal cord. Folate supplementation may mask true cobalamin deficiency, and while it improves anemia, will worsen neurologic deficits, so always check cobalamin levels. In early cobalamin deficiency, the methylmalonic acid levels might be elevated, so check early. Important, if cobalamin deficiency persists, it might progress to pancytopenia, so anytime patient presents with pancytopenia, absolutely must check B12 levels. They also develop high homocysteine levels with B12 deficiency, which may lead to vascular thrombosis. Treatment, 1,000 microgram intramuscular daily for 2 weeks, then 1,000 microgram weekly until anemia resolves, and then 1,000 microgram monthly maintenance. Or 1,000 microgram PO daily, but follow cobalamin level closely to make sure levels are improving, and if inadequate response, then change to ion therapy. If patient fails to improve with cobalamin replacement, check for thyroid disease due to autoimmune thyroiditis or iron deficiency. In a rare congenital disorder, Ehlers-Danlos syndrome, this causes impaired absorption of cobalamin by the terminal ileum. Folic acid deficiency, case report. 37-year-old female presenting with weakness, hemoglobin 6, elevated MCV, normal WBC and platelet counts, normal neurologic exam, normal cobalamin and TSH level, folate level low. Folic acid transports a single carbon fragment for production of nucleotides. The human body only has 3-month reserve supply of folate, so it may become folate deficient rather quickly, especially in vegetarians. It's absorbed in the duodenum and proximal jejunum. Causes of folate deficiency include decreased dietary intake, malabsorption, increased use such as hemolytic anemias with increased RBC turnover, alcoholics, and pregnancy. Folic acid deficiency has been associated with neural tube defects in the fetus. This is a very important point. Folic acid may become deficient in chronic hemolytic states, such as sickle cell disease, which will cause even further decrease in reticulocyte production, causing severe anemia. Case report. 40-year-old female with sickle cell disease, presenting with hemoglobin only 3.9, MCV 92, platelet count 160,000, normal WBC count, slightly elevated LDH and slightly low haptoglobin, indicating that the hemolysis is not that severe, but very, very low reticulocyte count, and negative parvovirus. Any issue that leads to decreased erythrocyte production in the chronic hemolytic patient will lead to severe anemia, for instance, parvovirus. Very easy to become folate deficient because you only have 3 months supply storage in the body in a chronic hemolytic patient, so should be on folate supplements. RBC folate level is a better measure of tissue folate stores than the serum folate level, since it does reflect folate stores over 120 days, which is the lifespan of the RBC. Treatment, folate, 1 milligram PO daily. Make sure that cobalamin deficiency is ruled out. Parvovirus infection with concurrent chronic hemolytic anemias. Case report. 60-year-old man with HIV in contact with grandson who has a new rash, keyword, now presenting with severe anemia and hyperreticulocytosis. Bone marrow reveals lack of erythroid precursors, but giant pronormoblasts present. Again, another keyword, pronormoblasts. So if you see a young person with a rash, now whoever was in contact with that person presenting with severe hyperreticulocytosis, think Parvo. Parvovirus B19, which causes erythema infectiosum or foot disease in children, may be diagnosed with PCR testing of Parvo DNA. Do not check antibody, as immunosuppressed patients will not be able to mount antibody to the virus. Parvovirus causes arrest of RBC production at the pronormoblast stage. Immunosuppressed patients, HIV or on immunosuppressants, are not able to clear Parvo, and pure red cell aphasia ensues. Anemia with severe reticulocytopenia, think either parvovirus infection or folate deficiency. Treatment, IVIG, intravenous immunoglobulin, and will appreciate reticulocytosis hopefully within 3 to 5 days. And supportive transfusions is needed. Anemia associated with endocrine abnormalities and liver disease. There are many endocrine diseases which will cause anemia. 1. Hypothyroidism will cause a macrocytic anemia. 2. Hypogonadism will cause decrease in erythropoietin production and anemia. Addison's disease cause anemia, which will improve with glucocorticoid treatment. Hyperparathyroidism is toxic to the microenvironment, causes anemia. Liver disease is a combination of GI blood loss due to coagulopathy and varices, underproduction anemia, increased destruction, and decreased RBC lifespan. Spur cells, RBC with membrane abnormality due to changes in the cholesterol composition. Always remember, replace folate and B12 if needed. Pure red cell aplasia. Case report. 20-year-old female presenting with shortness of breath and fatigue. Normal WBC and platelet count, but hemoglobin only 6 with very, very low tick count, 0.2%. Homestead negative, parvovirus negative, HIV negative, viral hepatitis panel negative, normal B12 and folate. Bone marrow biopsy confirms absence of RBC precursors. Keyword. Acquired pure red cell aplasia is characterized by severe anemia, reticulocytopenia, and absence of red cell precursors in the bone marrow, caused by viruses, autoimmunity, or drugs which inhibit erythropoiesis. Pure red cell aplasia is divided into acute and chronic disease. In the acute, can occur in the setting of chronic hemolytic anemia, in which an infection, either parvovirus, will cause severe reticulocytopenia, resulting in profound anemia. Drugs such as chloramphenicol, isoniazid, or gold salt, so discontinue the medicines, or anti-erythropoietin antibodies in the setting of treatment with recombinant erythropoietin treatment. 2. Chronic disease. Could be due to autoimmunity, seen in malignancies or autoimmune diseases, so check for thymoma, rule out lymphoproliferative diseases such as LGL leukemia and CLL, malignancies, or collagen vascular disease. Thymoma is thought to cause T-cell mediated autoimmune pure red cell aplasia and approves of thymectomy. Check peripheral blood flow to rule out LGL leukemia or CLL. Treatment: idiopathic immunosuppression, steroids plus or minus cyclophosphamide for months. If thymoma discovered, then perform thymectomy. Erythropoietin levels usually are very high, so recombinant erythropoietin is not effective. If parvovirus, IVIG. Medicine induced, stop the medicine. Anemia due to trace elements and nutritional deficiencies. Case report. 35-year-old female who takes excessive zinc lozenges presenting with anemia. What is the cause? Answer: copper deficiency. Copper deficiency may cause sideroblastic anemia. Copper is needed to convert iron from the ferric state to the ferrous state. Excess zinc intake may impair copper absorption, which will hence lead to anemia. Also important to note, anorexia nervosa will cause gelatinous necrotic transformation of the bone marrow, which will lead to anemia. And vitamin A and E deficiency may cause anemia as well. Nonmyelodysplastic sideroblastic anemia. Case report. 2-year-old male presenting with hemoglobin 5. The child has required frequent hospital admissions due to severe pallor and has received blood transfusions every 2 to 3 months since 2 months of age. There's no history of jaundice, fever, or bleeding. Liver is palpable 4 centimeters below the costal margin, and spleen is not enlarged. Bone marrow exam shows normal cellularity, ME ratio 1:1 with normoblastic erythroid maturation. There is no significant dyserythropoiesis. Myeloid and megakaryocytic series are within normal limits. And now keyword. Prussian blue staining reveals increased iron stores with presence of ring sideroblasts and 80% of erythroid precursors. Milestones are normal for age, no ataxia, and normal hemoglobin electrophoresis. Keyword is the increase in iron stores and ring sideroblasts. Presence of ring sideroblasts is a hallmark of sideroblastic anemia. Sideroblasts are erythroid precursors with excess mitochondrial iron contained as ferritin. X-linked sideroblastic anemia is characterized by mutation in the ALA synthase gene, which, as you recall, is the first enzyme in the porphyrin synthesis, which uses pyridoxine as cofactor. Secondary sideroblastic anemia may occur due to NBS, drugs, toxins, excess alcohol intake, or treatment with isoniazid. Treatment for X-linked sideroblastic anemia is 100 mg of pure pyridoxine daily. Anemia in HIV patients. Case report. 38-year-old man with HIV, not on heart therapy, presenting with falling CD4 count, rising viral load, fatigue, hemoglobin 7, low retic count, LDH normal, so not hemolyzing, Coombs test negative, haptoglobin normal, negative parvovirus PCR, ferritin and testosterone levels normal. Anemia may be multifactorial in HIV patients. Combination of chronic disease, infections, medicines, nutritional vitamin deficiencies, as well as possible HIV viral marrow infiltration. Important thing is, must rule out hemolytic anemia and hypogonadism. It's usually due to virus infiltration of the marrow, which decreases RBC production. Treatment: controlling HIV with heart therapy should improve reticulocytosis and anemia as the viral load decreases. If no improvement after 6 months, then begin recombinant erythropoietin therapy. Renal dysfunction and underproduction anemia. Case report. 68-year-old man with stage 4 renal disease presenting with anemia, normal WBC and platelet count, negative GI bleeding, workup for anemia, and no evidence of hemolytic anemia. Low reticulocyte count with low erythropoietin level. Kidney disease will cause a hypoerythropoietin state. Patients with chronic renal failure on dialysis will experience anemia due to 1. Increased inflammatory cytokines, 2. Ongoing phlebotomies for lab checks, 3. Increased risk of angiodysplasias in uremic patients, 4. Secondary hyperparathyroidism causing marrow suppression, and 5. Decreased erythrocyte survival. Treatment: recombinant erythropoietin. So epogen 50 to 100 units per kg once a week for non-dialysis patients, or darbepoetin 0.45 units per kg per week Q2 weeks for non-dialysis patients, or epogen 50 to 100 units per kg 3 times a week for patients on dialysis. Remember, do not treat to hemoglobin more than 12 as it may cause thrombosis. Iron: also replace iron to keep serum transferrin saturation more than 20% and serum ferritin more than 100. This concludes the underproduction anemias chapter. Thank you.